Okay. Good morning, everyone. So today, I hope I will talk late than yesterday or than the day before yesterday. No. So today we are gonna listen to your friend's presentation, and then it's like I think it's a wrap up of what we talked about last time. So in the first lecture of behavioral economics, we learned about irrationality, so behavioral biases. Mute, I'm sorry. Eddie, so we just recap. I'm so sorry. So, yeah, we talk about what's behavioral economics and about how we can use that. And here in this slide, we recap about if you want to understand any behavior. So we have this framework, and this framework is called COMBI framework. Says that this is a behavioral system. So for any behavior to happen, you need to have capacity, motivation, and opportunity. So, and it can subdivide into these 6 subdivisions that we talked quite extensively last time. And you can address each of these with different tools. And one tool is this mind space that you don't really restrict people options, or you don't push them or demand them, right? But you use this kind of soft intervention. So then this is the details about each one of them. And last time we also said that, of course, there are many other interventions, right? But this is just some that are proved to be effective in most cases. But of course, as I think you will see along these lectures, in presentation or in examples that I gave you, that there are not many studies in low middle income country actually, so it's still a gap for us to do. Okay, and so we are going to listen to your presentations, and so each of you will have maximum 10 minutes, so that we will spend like 50 minutes for presentations, and then we will take a break. And after that, we will do this small workshop so that you can design your own intervention for your interested behavior. Okay, but we will go into more detail after the break. Okay, so I think it's time for the presentation. Have you choose the order already? So it's easy for you, like you can, or should I make should I choose for you, or you can volunteer? อะไรวะเนี่ยเดี๋ยวนะ I'm sorry. Oh, it's recorded. The television downstairs doesn't work. We can try to fix, but okay, who would want to be the first? I will fix that later. ตามเรื่องใช่ไหมนี่ใช่กำลังนึกมันจะมีคนที่ได้ sorry who got the availability bias I think it will be availability bias and overconfidence, the first two. So Ajahn Ice, you want to share You want to share or you wanna come?
Let me share.
Okay. Thank you, อาจารย์เอิร์ธ And yeah, try to relax นะคะ It's just like you read the paper and you tell your friends about it. So okay. Good morning, everyone. Today I will present journal presentation. The title is Effect of Availability, Bias, and Reflective Reasoning on Diagnostic Accuracy Among Internal Medicine Residents. The authors are by Sylvia Mamede and the others. Research question. It didn't state. I interrupt a little for every one of you too. So when you present, can you go back to your title page? So when you present a paper, please give the title, author, and also where they publish. So it's like people can have reference. I will change it when I submit the. All right, thank you. And there is a question is availability bias associated with diagnostic error, and would clinical reasoning counteract it? Objectives. To find recent experience or encounter case with similar clinical manifestation might provoke any availability bias, and to find that reflective reasoning would counteract this bias. From this summary, we can see that the patients or participants are 18 first year and 18 second year internal medicine residents from Erasmus Medical Center. And the intervention would be, they would first evaluate diagnosis of 6 clinical cases in phase 1, and then they would diagnose the case with findings similar to previously evaluated case, but with different diagnosis in phase 2, and then in phase 3, 4 cases would subsequently diagnosed again, but this time they would ask to do by step by step of reflective reasoning. And the result came as significant interaction effect between years of training and recent experience with similar problems. And result would be consistent with an availability bias occurred for the second year resident. Study design, it is an experimental design study, and the participant is all included 36 internal medicine residents from the Erasmus Medical Center, the College of Medicine. And the cases are 16 written clinical case, selected and confirmed diagnosis by 2 experts of internal medicine. The case that has been given would be consist of brief history, signs, symptoms, and test results. And for one phase, it would consist of 6 cases. It would be 4 neutral cases and 2 cases of disease that have signs and symptoms that also frequently encountered in 2 other diseases presented in phase 2. The participant would be given 2 booklets with different sets of cases in phase 1, and they would be randomly. Analytical method was done by ANOVA. This is how the phase process. In phase 1, each case has a diagnosis list, and participants are asked to rate the likelihood as in percentage that this diagnosis was correct or not. And in phase 2, all participants were asked to diagnose all 8 new cases. And this time it would be the same for all participants. And they are asked to give out diagnosis as quickly as possible. So in this phase, we can expect that there may be some availability bias for some of the doctors that they get the experience and they tend to give out answer more fast. But they tend to give out the answer faster because they are asked to do as quickly as possible. So they tend to use their experience as a base. And in phase 3, participants were asked to diagnose the 4 cases from the phase 2 that could have been influenced by the previous exposure or from the similar encountered cases. And this time they are asked to do by instruction of reflective reasoning. They would consist of something like what is the prominent sign symptoms? Could you list the things that it should be there, but this case I didn't give it, something like that, so they can take a time and then think about it. This is the details of the case. They are divided in set 1 and set 2. For case A, set A it would be acute viral hepatitis, and case B, inflammatory bowel disease. And we can see that in phase 2, there are something like liver cirrhosis that we can have manifestation that's similar to acute viral hepatitis, or in celiac disease that would have signs and symptoms similar to inflammatory bowel disease, as in set 2 as well. And this is one of the example of the case when we see about the physical. This case is celiac disease, but if we try to look at it like really fast, we will see something like, and the laboratory test that with some experience, we might think that, it can be viral hepatitis or something like that. So, for the bias that might occur in this study, I think first it is anchoring because the doctors that are doing the test, they might start from their experience and then they try to find out some evidence or some manifestation that go along with their expected disease, and then they tend to give that answer. And then there are availability bias, which is because they have that experience and the memory could resurface easier. So they tend to give out that answer more than they do it by reason. And this table told us about the persistence of the diagnosis that the result between first year and the second year of internal medicine residents. We can see that in the first year medicine, if they are encountered with similar case, they tend to give out all the wrong diagnosis less than the second year internal medicine resident, because in the second year they have a little more experience and they tend to believe in themselves over time. So they might think that the experience would help, which it could be the basement of diagnostic error. And the strength of this study, it is an experimental research, which is quite rare in the field of availability bias and limitations, because resident from 2 years, there has not been said or corrected would it be the same or would it be persist in the later years that they might grow up or they have more experience, or would it affect as well in another specialty. and the similar problems may not always come like case by case that we can expect like in this practice, and restriction in generalizing these findings like that are given in this study might come harder than this situation in real life. In conclusion, we can say that availability bias may occur in medical diagnosis as a consequence of recent experience with similar cases under non-analytical reasoning conditions. And availability bias tend to be larger for more experienced residents, and they have tendency to diagnose case through pattern recognition increase with clinical experience. So it might be the gap of knowledge that when the doctors have more experience, or we can say that maybe some of the staffs or third year may have more error because they tend to believe in their experience more than reasoning reflective. And the opposite pattern for the first year resident, they have better performance in similar case because they still think about the case by reflective reasoning, because they tend to not believe themselves, not to be overconfident. Thank you. Thank you. So what's your personal opinion on this? How do you like relate to the practice? Your daily practice? Yeah, in my daily practice, like if I need to apply in occupational medicine, it is like similar, because if some of workers are coming to me and they say, do they have a wrist pain? I tend not to think about the gout or something like that, because I read more about carpal tunnel disease or like a trigger finger or something like that. So I tend to think more about my specialty other than any other disease that in fact it may be more frequent than my disease, something like that. And do you think it's like a serious issue, or you think about how to maybe avoid this bias? For myself, because if I need to diet someone by occupational disease, because if it's occupational, I can counteract with the history of work, like working history. Is this enough? Is it the job description of patient match with the disease or not? So we have something like step, that we need to think about if we want to give out diagnosis. Yeah, that's cool. So maybe, without, I mean, it's naturally that maybe in your area you notice this can be bias, and so you try to develop a tool to help avoid this bias, this common bias. Okay, very good. Thank you. And your friends, do you have any questions? No. Okay, so the next should be the overconfidence one, I think. That's a mile. She just finished the slide. During your presentation. Yes, we all learning.
Okay, good morning, all. My research article today is about the overconfidence bias, and this article title is Physicians that toxic accuracy, confidence, and resource research, which is published in JAMA Internal Medicine in year 2013. So most of the words that write down in this article. That is the keyword of this article is the diagnostic accuracy and physician confidence. When these two things are aligned together, the confidence can reflect the accuracy. For example, if you have you will have high confidence when you have high accuracy of the diagnosis. But if these two are misaligned or miscalibrated, in the way that the confidence is lower than it should be, it will result in underconfidence, and it will lead you to seek for more additional diagnostic resources to raise your confidence level. On the contrary, if the confidence is higher than it should be, you will not seek for additional diagnostic resources, and it will lead to the diagnostic error, which we don't want this one. So, the relationship between the accuracy and the physician confidence, we call diagnostic calibration. And the researcher wants to know if the physician faced with the more difficult case or during the diagnosis process, that we get more information during the process, how diagnostic calibration or the accuracy or the confidence change. So for more understanding, I format the research question into the equal format. Since this study has two main things to compare. The first one, the researcher wants to compare if the physician faced the difficult case. So the population will be the general internal medicine physician, same as the diagnostic evolution. And the outcome that they want to see is the accuracy of the diagnosis, the confidence, the diagnostic calibration, and the request for additional resource. So the thing that different is if they focus on the case difficulty, the intervention and the comparison is the easy case and difficult case. But if they focus on the phase of diagnosis, the intervention is and the comparator is the each phase of the diagnosis. So the research objective is the primary research objective is to evaluate the diagnostic calibration change when the evolution of the diagnostic process and with the increasing diagnostic difficulty. And the secondary objective is to explore the relationship between the confidence and the request for additional resources. So the method of this study is the researcher recruit the physicians from an online community and ask the physician to diagnose 4 cases. Two are the easy cases and 2 are difficult cases. And the participants give the answers in the text format. And the case that present to the physician were divided into 4 phases in order to simulate the diagnosis evaluation. Here show the procedure for more understanding. The participants or the physician who join this study will be provided an information about the chip complaint and the medical history in the first phase. After finish this phase, the physician have to list down 3 differential diagnoses and give the confidence level of each diagnosis. After
Did you see how they rate the confidence?
The researcher let the physician rate themselves with the score from 0 to 10.
Okay.
Thank you. After finish the phase 1, the researcher provide more information about the clinical examination and let the physician list down 3 possible diagnoses and break the confidence again. And after phase 3, that the researcher provides the information about laboratory and imaging. The participants respond the same and add for one more thing is that the researcher will ask the physician, do you want to require for more additional resources? And after phase 3 and the phase 4, the researcher gives the definitive special or specialized laboratory and imaging, and the physician have to list out one final diagnosis and rate the confidence of this diagnosis. So, in conclusion, the outcome of this study is the accuracy of the diagnosis that compare the answer from the participants to the true diagnosis. And confidence data is rated on a scale of 0 to 10 and calculate the diagnostic calibration and the request for additional resources in dichotomous outcome response. So here is the result. The left graph is for the easy, the accuracy, the diagnostic accuracy and the confidence of the physician for the easy case, and the right graph is for the difficult case. You will see that for the easy case, the diagnostic accuracy is around 50%. But for the difficult case, the accuracy of the diagnosis is around 5%. If you compare the easy and the difficult case, you will see that the diagnostic accuracy decreases when the physician face more difficult case. But the confidence on that diagnosis, you will see that in the easy case, the confidence is around 7. But for the difficult case, the confidence is around 6. You will see that the confidence level is almost the same for the easy case and difficult case. It means that when the accuracy decreases when the physician faces the difficult case, but the confidence level is it's not changed. So the calibration, so these two are less aligned. So the diagnostic calibration is worsened. And the confidence, which is still the same, but the accuracy decrease, it shows this miscalibration in a way that it shows overconfidence. And you will see the magnitude of the overconfidence in the difficult case. When the physician faces with the difficult case, the overconfidence is increased. In other aspects, different aspect from previously, this aspect is when you diagnose the case, there are 4 phases. It means that you gain more information, and let's see that accuracy and confidence change when you get more information during diagnosis process. You will see that in the process of diagnosis phase 1 to phase 4, the accuracy remains stable at the first 3 phases of the diagnosis and slightly decrease at the last phase when you gain more information, both in easy case and difficult case. And the confidence level
So it's like more pronounced in easier cases. Like,
Yes,
yeah.
the magnitude is
For the more difficult cases, it's more stable, I think, across phase. Yeah.
and the confidence level varies slightly across the diagnostic phase. And the confidence level is highest after phase 3 that you receive the physical examination data, history taking and general testing. You see that the calibration, diagnostic calibration worsens slightly during the diagnostic phase 3 and phase 4. And for the easy case, overconfidence is slightly higher in the post phase of diagnosis. But the difficult case, even you have more information, the confidence level is higher, but the accuracy is decreased. So the overconfidence is higher in both phase for the easy case, but for the difficult case, since the confidence level is at a higher level throughout the diagnostic process.
I mean, if you imagine how when people answer the questionnaire about how confident you are, so there might be like, I am 6 or 7, for example. So it doesn't really matter. I don't know. I'm thinking. Yes. Okay, but okay, the accuracy decrease. It's like when I'm confident, right? So I'm in this level of confidence. Of course, it's nice to see how people are more confident. Yes.
Next part of result is about the request for additional resources. In this study, they consider the additional resources are additional diagnostic tests, second opinion, consultation, referrals, and reference. And to see the relationship between asking for additional resources and confidence. The numbers show the odds ratio, which is less than 1 that in the blue box. It shows that when the confidence level is higher, you will request for the additional diagnostic test lesser. If you see the column, the right column show the accuracy of the diagnosis. It's not related to the request for additional resources. It means that you will request for more resources from the confidence level, regardless of the accuracy of the diagnosis. And when you face with the difficult case, the only resource is that the physician likely to request with the reference material rather than second opinion, referral, consultation. It's short, not significant in this study. And when the physician who have high experience will request less additional resources, and the researcher implied that the experienced physician will have different way to approach the diagnostic process. And the character that related to the request for additional resources in medical school may show that medical school training might influence the way physicians help in making diagnosis. So the strength of this study is that this study directly examines the relationship between accuracy and confidence within the context of evolution of diagnostic process, which never studied in the previous study. And the physician who is the participant of this study directly rates their confidence, which is more accurate compared to the more
in relative
to relate to
Yes,
other
yes.
studies if that the participant not directly rates the confidence. And the participant in this study have a wide range of practicing physician. So, and it is the same distribution of the physician in the US. So it's good not to it's good to generalize this result to US country.
That's what the author said.
Yes.
Okay.
And the limitation of this study is the method of care delivery limit the validity of the study. And to categorize the accuracy of the diagnosis rely on the manual coding that may lead to the bias. And physicians may have unwilling to disclose uncertainty as I said that why they break the confidence.
Yes, when it's self-report, it's always, you have to question that first, but of course, that's the best way so far. So, yeah.
And actually, there are many factors that can affect the request for additional resources, not only the confidence or accuracy. That is not measured in this. So the conclusion is that you will see that the confidence cannot replace the accuracy of the diagnosis. So the association between these two have worked. And the overconfidence increase when the patient faces with the difficult case and even when they get more information for the diagnosis. So the physician level of confidence may be relatively insensitive to diagnostic accuracy and care impact. So it might prevent physicians from re-examining the difficult case when their diagnosis is incorrect. So to improve this association and the use of the resources can reduce the diagnostic error.
How can you? Thank you. But yeah, they say improving this association potential resources. Maybe it's like what Ajahn I said. So you develop a tool that systematically help you to overcome this. Not overconfidence, maybe people are always like that, right? Because it's our nature, right? But then yeah, you develop the tools like guidelines, not that checklist that okay, you have checked that already, and or you ask again, like, are you really sure about this and that? So the system can help a lot. Okay. Thank you. And then we have so that's and then have one. So I think the next one should be this one. Okay. And actually, I would like to encourage you, like when doing presentation, and you have some question and you want more clarification, you can also ask asked during the presentation. Sorry, I didn't tell you before that. Like maybe it's not the way in CEB, but I think it's more lively.
So good morning, everyone. I'm gonna present my assigned topic.
อาจารย์ก่อน assign for you.
Yes.
Not me, na.
Okay. So this one is the Association of Primary Care Clinic Appointment Time with Clinician Ordering and Patient Completion of Breast and Colorectal Cancer Screening, which are published in JAMA Network, open on 10th of May 2019. And this study conducted in Pennsylvania, US. So let's start with introduction first. They say that cancer is the leading cause of death in the US, and the guideline recommended that the primary care physicians should offer the screening test for breast and colorectal cancer for patients. But you can see that 37% of adults have not been screened for colorectal cancer, and 28% of women hasn't been screened for breast cancer. And they say that this may be like from too much thing to do in too little time that the physician have, and maybe they find that in other aspects like in influenza vaccine giving, they can see the pattern that later in the day, especially after the afternoon, the rate of prescribing the vaccine is like get lower and lower. So they think that this may be about the cancer screening, maybe have some problem like that too. So come to their research objective that they want to evaluate the association between the time of day for primary care clinic appointment and the clinician ordering, and also the patient completion of breast and colorectal cancer screening. Let's see their method first. I postulated their PICO framework first. The patient is the adult eligible for breast and or colorectal cancer screening. The exposure and control going to be the time of the day for the patient for primary care visits during the study period. And the outcome, they have primary and secondary. The primary outcome is the clinician ordering the screening test, and the secondary outcome is for patient to complete that test within a year or in that year that they come to visit. The study design is a retrospective cohort study. Setting is going to be 33 sites of primary care practice sites of the University of Pennsylvania Health System, including the internal medicine and family medicine clinicians. Participants going to be adult eligible for colorectal and breast cancer screening. For adults, their inclusion criteria is that first new or return visit in the primary care practice at one of their practice sites of their 33 sites, and the exclusion criteria is going to be the other type of visit like acute care or sick visit, and if they're inconsistent PCP during a year or no PCP visit during that year, or previous breast cancer or colorectal cancer screening completed, they will be excluded. About the colorectal cancer, it's going to be for patients who age around 50 to 75 years old, while the breast screening is going to be female, of course, and age 50 to 74 years old. Study period is from September 2014 to August 2016. The data collection. First, they collect the patient data, which are the demographic data, insurance, comorbidities, primary care center, and presence of cancer screening tests. They also collect the clinic visit data, which are date, appointment time, practice site, and visit type, and also the presence of order of cancer screening tests too. For colorectal cancer, they can be either colonoscope, sigmoidoscope, FIT, FOB, or multi-targeted stool DNA. For the breast cancer, we have only like mammographic screening. The outcome, as I told before, have primary outcome for the clinician ordering, and the secondary outcome is the patient completion the test within the year. There's the statistical analysis during the work time, which are 8 a.m. to 6 p.m. They group it by hour, like if they have appointed at 8, 8:15, 8:30, or 8:45, they group it at 8 a.m. And 9 a.m. it's going to be like 9, 9:15, 9:30, 9:45, and so on.
What about 9 and 8?
Right.
I'm sorry.
The appointment time should be like this. For the statistical analysis, they use the conditional logistic regression condition on the primary care practice. Because some doctors may only practice in the morning or in the afternoon, and they so also adjusted for demographic, insurance, and Charlton comorbidity index, clinic visit type, and fixed effect by the practice site. And the Charlton comorbidity index is like a list of disease, and they have score for each disease. And for like the more severe, gonna have more score. Let's look at the result. So
Have you heard about that before? Charlton something.
I know. Me also. And for the breast cancer first, there are around 20,000 people eligible for screening. The age is around 60, and all are female, of course, mostly are white. While for the colorectal cancer, it's like around 33,000 people, and mean age is nearly the same, it's around 60, and female is nearly half, a little bit more than half, 55%, mostly are white. For this one is the result of the unadjusted rate of ordering and completing screening, cancer screening.
But sorry,
yes.
may we go back?
Yeah.
I just want to see the insurance.
Okay, so the insurance mostly is private,
Oh,
most of them are private.
in the US. So Medicare is for old people and Medicaid is for low income, right?
The-
I'm not sure. Like, I'm always confusing about these two.
Likely, Medicaid, like for the people who have,
Yeah,
low
low
income,
income and Medicare for older people. Yeah,
but mostly also
So,
most of them private,
private.
and their income around like 50,000 to 100,000 annual household,
Okay.
mostly a good condition.
I'm
Sure.
just thinking about how. But that means all of them are insured somehow, right?
Yes,
Is it, okay, so it shouldn't be. I'm comparing to Thai context that we have different insurance scheme
Yes,
and
yes.
it may also impact or influence doctors' decision whether to send them to screening, right?
Yes, sometimes. Due to the scheme, it has some effect on the ordering the treatment too.
Okay,
Yes.
but okay, in like for when we analyze the data, we just say, oh, we control for it already. Yeah, okay, please continue. Thank you.
So look at the breast screening first. You can see that the rate of ordering, which is in the blue, green line, whatever, is gonna go down during the time of the day, like in the 8 a.m. you have rate of around like more than 60, and then it's gonna drop down until 11 a.m. and then after lunch, a little bit come up, and then going down during the time of the day. And this method can be also seen in the patient to completed the screening, cancer screening too, nearly the same. While for colorectal cancer, it's still the same, nearly the same pattern as you can see in the breast cancer screening too. The order and the completement also come down during the time of the day too. And if you adjusted the odd, you can see that the lower odd of ordering is at like 4 p.m., which only like 0.5 and also the odds of
compared to 8.
compared to 8 a.m.
Mhm.
Yes, compared to first time of the day. It's coming down. You can see that the pattern is going down all the way, and all of it are like statistically significant. And for the patient to complete is the lowest at 5 a.m. And also the same as the colorectal cancer, as you can see. Comparing with 8 a.m., the odds of ordering is become lower and lower during the time of the day, and lowest is at 4 p.m. too. While the completion of the patient also coming down and lowest at 5 p.m., which are the same as the breast cancer. So they discussed that during the time when the time passed by, the ordering and the completion also come rate is like going down all the time. So they discussed that it may be from declining order or for the screening, maybe from decision fatigue for the physician, because like they have to make some decision during the day, like to treat some patient or make some decision, and maybe at that time they feel like, oh, I don't want to like do anything that have to make more decision anymore.
You know, we all know what fatigue means. Fatigue is like synonym for tiredness. Like you have this cognitive bandwidth, and then you work all day, and then maybe you are like cognitive, is overload, something like that. Okay.
Yes, and another thing may be that when at the morning, early morning, maybe the physician come and like feeling like, oh, today I'm gonna screen for the cancer. Everybody will be, I will let everybody screen, and then at that time, some patient may be refusing to give that, oh, I don't want to do it, or I don't have time to do it, and maybe after some refusion for some time, maybe at the end of the day or the later of the day, they're feeling like, oh, I don't want to bring this topic anymore. So maybe the patient who come later will not be advised for screening cancer anymore. And another thing is that maybe their work is behind their schedule. Maybe they have to finish like around 6 p.m. at that time. Maybe they want to like, oh, I have to finish in time. So they want to shorten their conversation with the patient. So that's why sometimes they don't bring up the cancer screening title to discuss with the patient. And for if you look at the patient aspect, they say that maybe in the afternoon, maybe patient want to come home sooner because it's going to be late if they have to talk. So maybe they refuse to talking about the screening. And this may be because they think that it's only screening, it's not the direct health issue. So they just like, okay, so maybe next time it's okay.
May I ask about the context a little bit more? So in this context, if physician send the patient to screen, it will be on that day, like in
Okay,
or it's like appointment for other day, like in Thailand.
It's gonna be in the other day, and also the different site too. Means that they when they have been ordered for screening, like breast cancer, they have to go to other hospital or other clinic to appoint, and then to go again to make the test. So, and that is one of the discussion that to say that maybe that's why the completing within that year is like lower, and also when in the later of the day, afternoon, maybe some of the patient don't want to like don't like to go to the other clinic or other place at that time. Okay, so it's same pattern, both ordering and completing the screening test. So the strength of their study, they say that they have large sample size, and they say that they are the first of their kind to explore the association between appointment time and the ordering of the cancer screening. But the limitation is that they are only primary care practice in 2 states, and it only single health system and they cannot access the insurance claim record. And maybe some patient and physician factor like educational level or the burnout of the physician. And they say that they are observational study, so they may have some like bias or confounding. So they conclude that time of day may significantly influence the clinician ordering and patient completion of cancer screening tests. And they say that future intervention should consider this factor for improving cancer screening, and they just stop it there. That's all what they say. So I try to think that, so what should we do to improve it? Because they just only like give us only the phrase that future intervention should consider this factor, but how or what? So after like 2 or 3 nights of thinking.
Wow.
I really,
You brag.
I really want to know.
Yeah.
So how should we improve it? How? So one thing that I come up is that maybe we should separate the clinic, like the clinic for primary care, for disease, and this section or this group of physicians, maybe this day you only for screening or like testing, or maybe we can do it like separate it, like for the screening, maybe we can do it directly to their place, or maybe to somewhere near their house, to just let them like walk by and then ordering them, because whether you come to the clinic or not, the screening test is gonna be done at other sites.
Yeah.
Actually, so maybe it's not important to come to the clinic to just like order for the screening. So maybe if you separate the staff for doing the disease and the non-disease group, I think this one can reduce the fatigue of the physician, and also reduce the problem about that. They say that it's gonna be like behind schedule. It can reduce that problem, and also if you separate it, the patient who come to this sector, they will know that, hey, I'm gonna talk about the screening. So you don't have the problem of that, oh, I want to go home early, I don't want to talk about this. Today I come only like for something, I'm gonna get my flu shot and then I don't want to talk about screening. So if they know directly beforehand, I think it's gonna reduce this problem. And that
What do other things about this recommendation? That's very nice.
One thing that quantitative intervention that he success when they be in for me, like if you want to separate the clinic, it's about environment to change the ambulance. One aspect to change the ambulance. Another aspect, if I try to link to the lecture, like the checklist for screening to deal with the fatigue of the doctors. If the patient meets all these criteria on this checklist, they have to screen to the cancer or cancer. It's named or like the default something.
I'm just thinking about the context where they were doing this. It's like people come to just have, it's just they come for their disease, and then if they are like in this criteria, so the doctor ask them about or tell them about the screening, right? So it's like very hard to like you have separate appointments for screening, but also they have to be this targeted. I mean, they have to be this patient you want to include them, right, to screening.
yes.
So I'm thinking too. But I think that's very nice of you that you, or it gives me a lot of moral support when students like think about the issues. And this is a very nice study to show. I think it's the part of a bigger study, I guess, that they want to increase screening rate. So, and of course, they think about the intervention or they try to come up with interventions, but before that, they have to really investigate what are the factors that that make screening rate low. So they try to study many aspects and also using many study designs, like maybe they do some experiment, also they use their existing data, so they explore what can be the causes, and then after they know about what's happening there, so they try to come up with intervention. I think the Penn this research group is a very big group for behavioral science, for health behavior. So that's very nice of you, and yeah, that point out this. So that's why you can see there are some studies trying to find evidence for what actually maybe you think you know it already, like, yeah, of course, later in the day, doctor prescribes screening rates, but this is like they show the evidence, like in that, like you can see and you can judge their study design whether it's reliable or not, and whether you should believe it or not, so you can do this appraisal. And of course, come up with an intervention is not easy. So yeah, we can think about it more. Okay, so it's okay now. We are a bit behind, but I think we can shorten the time for the workshop. It's okay. So next would be Ping Ping or Eddie. I think topic-wise, either of you is okay, but if Ping Ping wanna go. So this is yours?
I can go.
Yeah. Mine. Okay, Eddie, wait for, it will be the last one.
Okay.
Okay. So then what have you choose to unshare first? Or is can you okay. This is my favorite paper, so you should do a good one. Sorry, I don't give you pressure. I like all the papers I chose for today.
So my presentation today is about the monetary incentive to increase the COVID-19 vaccination. This article is published in the Science, and in year 2021, the author is called Compost Message, and the study conducted in Sweden. So the presentation includes the objective, method, result, stage, and limitation and conclusion. So a short introduction. As year 2021, the COVID-19 pandemic is ongoing. So this study is want to study about how to increase the rate of the vaccination by the monetary incentive. So objective of this study is to determine the effectiveness of the monetary incentive in increasing COVID-19 vaccination rates. And the method, because their participant is the Swedish population that aged from 18 to 49 years old. And the intervention is monetary incentive of for the Sweden money is 200, and it's around $24 US. If they got vaccinated within the 30 days of the vaccine become available for them. And the comparison is got three main group. The first one, they got the control condition. And the second one is the behavioral nudge of three kind of nudge, the social impact condition, argument condition, information condition. And the last main group is the no reminder condition. So this study is the RCT, and they use the online survey to conduct the study, and the outcome is participants of self-report of the intention to get the first dose of COVID-19 vaccine within 30 days after the vaccine become available for them. And the second outcome is whether they really get vaccinated within 30 days according to the record of their public health data.
May I interrupt a little? So you could see, or you could consider behavioral nudges as other intervention as well. So, I mean, it's like you compare different interventions, right? And yeah, just to add, but nothing wrong here. But I would like to ask here, are you going to describe what is the difference between control condition and no reminders? Or you mean these two are control conditions?
I will explain it
Okay,
about after this.
I see.
This is the framework, the flow chart of their progression. And they have the online survey for their population around 9,000 individuals. And around 8,000 individuals have completed their online survey. And they divided into these 6 groups. And after that, they send the email for different by the group that they divide. And when they finish, they link these individual with their vaccine record, so they can compare that what is the outcome and the intention. So to explain about the intervention and comparison, as I have said before, the monetary incentive only have one group, around $24, and the comparison group for control condition. One thing that's the same is control condition and behavioral nudge group. They will send the reminder to encourage their population to get vaccinated as soon as possible. But the no reminder condition, they will not send the reminder, will not send the nudge, no anything.
So control, there is a reminder.
A reminder.
No reminder condition means nothing at all.
Yes.
Mhm.
They got a very complete database. They got the vaccine record of their population that they can link to their RCT data.
That's the developed country. You can link the admin data to survey. No, but like Sweden and like Denmark, Scandinavian countries, they have really good health record and admin data where you got anonymous data. It's not leaked as well.
I'm very surprised because I think 8,000 is a lot, and they can link all of them.
If you want to do a study, like they have a 30-year cohort or something from Sweden and also Denmark, you can, as foreigner, you can also register and ask for the data. Okay. But are you going to the details of the behavioral nudges?
Yes.
Okay.
So for the behavioral nudges, which include 3 types, the social impact condition, they will want the participant to make a list of 4 people who would benefit from there to get vaccinated, like their family, their friend. The argument condition is they ask them to write down the argument that could convince other people that to get vaccinated. And the information condition is ask the participant to include participate in a quiz with the condition on the safety and effectiveness of COVID-19 vaccines. So it's like the class of the benefit of the COVID-19 vaccines.
Okay, so if you compare to what we learned last time, so social impact condition here, researchers ask participants to like name the people who will benefit from like ask Supari to list people who will benefit from Supari vaccination, right? So it's like you use this I would say it's effect. That okay, I think about people who I love or things like that. And argument conditions here, I need to write an argument that could convince other people. So I need to think about the benefit really hard. Yes. So it's kind of they try to address my reflective thinking. No? Like the last one as well. So you asked me to answer about the information about the safety and effectiveness. So I have to think rationally. So think about the benefit. So I shift to use my reflective motivation.
So maybe it will make a positive consciousness about the vaccine.
Yes. I think it's the same domain, but just like the last one is very straightforward. Like you ask me some question and I need like it's like a test. But the second one is more sophisticated. So if I want to convince another, so I have to think harder, I think. I think that researchers, they think that way.
I remember that one of the argument that other people spoke to me about is that if you get vaccine, you can go abroad to other country. Because it's the threshold about the
Or the second one, or you other people can add me as well. So what do you think that is the difference between the second and the third one? Like as you Ping said, then I think about okay, when I have to come up with the argument I want to convince other, maybe it doesn't have to only be reflective argument, but it can be also like, oh, you can go abroad.
you can go travel.
So it may be something that really matter to you that you think about.
Okay. So I will go to next slide for the result. The result they compare the control condition and the incentive condition for the intention to vaccinate. The control group got 83% and the incentive group got the 87%. It's a bit higher than the control group. And the uptake group, vaccination uptake, which is mean they really got vaccinated. The control group got 72% and the incentive group got 76%, which both are higher, have the higher impact for the incentive condition.
So intentions you get from the questionnaire.
Yes.
You ask people whether they wanted to get vaccinated or not. So it's a self-report. But vaccination uptake, you get it from admin data.
Yes.
Okay. So it goes in the same direction. When people are have intention to get vaccinated, then some of them really get the vaccine.
And this data, the period of time of vaccinate will be within 30 days after it's available. And the second analysis is they compare it with NASH about the like effect size of the vaccine. And people who receive the monetary incentive get vaccinated increase that higher higher than the pool of higher than the control condition by the 4.2 percentage point. And the pool data from 3 NASH condition, they pull it together, the social impact argument and information condition, evaluate the vaccination intention by 1.8 percentage, but for transfer to the real vaccination uptake is only like 1.2 percentage, which is not very statistically significant.
In pink, when you show a graph, you need to explain the graph. Like what is the y-axis and x-axis here? See it as a training, okay? It's not like I give you negative feedback, but it's encouraging because you have to do a big presentation in other classes. Yeah. Every time when you show the graph, you say, what is the graph about? And which what the bars explain.
So the field circle is the vaccination uptake.
Okay.
And the unfilled circle is the intention. And this graph show the effect size of 6 group of participants.
Yes, and what can we see? What is the zero line? You read the label here, regression estimated impact in percentage points.
Yes.
Okay. So 0 means it's like no effect compared to, is it compared to anything?
I think they compare to
No, it's just efficient, I think.
when I read they like said about compared to the
It's a control condition.
expected risk. They expect.
Yes, in control conditions, you see the last one versus the control condition. Control condition means you don't get anything.
Only get the reminder.
Only get reminder. Okay. So you see the no reminder, right? Compared to control is negative.
Yes.
That means get some reminder might be better than no reminder at all. But you see the bar is the confidence interval. And it covers 0, that means it's not significant. Okay, and for the nudges as well, you see the nudges.
Yes.
So
the pool nudges is a bit high. The intention and the uptake are a bit higher than the 0 point, which is the control group. But it's only got around one higher than the 0 point.
1.2 that you have in the.
Yes.
Okay. So that's the uptake, the real uptake is 1.2 percentage higher than the control condition. Right?
Yes.
But it's not significant because you can see the confidence interval is cover 0. That means some of the people so the distribution is not always on the positive side, but some of them come to the negative side. That means you cannot really confident that it will be higher than control condition. Yeah, but for like the mild one, what you can see. This is the intention.
Yes.
But the intention here is you can see the confidence interval all in the positive area compared to control. That means you can see that people in pool for all nudges, they have higher intention than in control group to get vaccinated, but then only some take the vaccination up. So, and here they separately look at each nudge, each type of nudge. And you can see that it's quite, it doesn't really work significantly.
Yes, only social impact and argument a bit better than the information, but
Okay.
when they really get vaccinated, it's still not very significant.
So,
And
yes.
And this is the compare with the no reminders condition.
Yes, we have talked about that.
Yeah. So get to the last analysis. They also collect the click of the link they send to online survey about the information different by the group. Like for they send the questionnaire about social impact to the social impact group, the argument for argument group and information about the quiz for the information condition. And it can see that the desire to click in the link is the incentive, the mandatory incentive get high, very higher than the nudge, which people will not much want to click on the like this kind of questionnaire. Okay.
Why is now?
Because no reminder is which is mean we don't send anything to them.
Anything to click.
But for the incentive, we send like, oh, if you go to get vaccine within 30 days, we will give you $24.
Is a control group, which is a 0 line.
Oh, yes.
But yeah.
Yes.
But I don't think it's here because they don't have any link.
Then they will send the remind for.
They send only reminder, but without any link, maybe. Yeah.
Because the remind is just send you some information that you can is a vaccine that available for you to get.
But you need to check again.
I will check.
No, it's related to control condition here. That means in control, you send reminder and a link to do appointment. Yes, so here is the coefficient. But then you have control condition as a reference case. Yes.
Another question about the previous
Previous.
I don't know why we use the reminder as a control, why we use the reminder as
I think it's very
good point. If any one of you wants to try to answer.
because I think I also think that is the no reminders more likely to be the control group because if no any exposure in this group.
What have you some guess? No?
reminder is one of the things.
Yes, but so when we say because for incentive and other nudge, the people have to get reminder. Like to get some contact from the researchers, right? First, they have to get something to tell them that, okay, if you go to like get vaccine, you will get this much. So you have some SMS, for example. So it might be the effect of getting some SMS and incentive together. So that's why, or for nudges, then it can be the impact of getting SMS and then this kind of nudges. That's why the researchers want to really disentangle the effect of getting some SMS and so the impact of like the content of the SMS. That's why they use getting like a neutral reminder as a control. But of course, that's very careful of them. So they also think about no reminder at all. That's why they have another like super control condition.
For the I can add something. For no reminder, they is choose by themselves that I don't want any email about this after they complete the survey.
Okay, so they just so it's not randomly assigned. So
For no reminder is they choose by themselves, but all the group that is randomly.
Nice. Okay, so they just wanna show what happen if people don't get reminder at all. Does that answer your question? Okay. Because just if you get any reminder, it might already impact your, it's just salient that we learn about.
Because I think they may all know about the vaccine that is available soon, but not very clear about the information if they know the reminder.
Or they just forget and and you just send them some SMS and it just remind them. Like yesterday who crossed. No, lost your key. Because we talk about it on Tuesday.
I already forgot it.
Oh.
No
Let's
reminder
see
group.
today.
No reminder group.
Okay. I can. Okay, please continue.
So the strength and limitation of this study is the really direct benefit is boosting the research to get vaccination, and they get really vaccination, which lead to the more safety in the community and to protect them from the COVID-19 and lower the hospitalization rate for medical field. And a key consideration of this study is paying for people to get vaccinated is lower cost for society than the sum of all the payments for get hospitalization, for get the disease, for get pandemic.
In that period.
Oh yes,
Yes.
2021. And the limitation of this study is that they only got one size of monetary incentive, only $24. So it's not clear that the smaller incentive or the larger incentive will have more effective. And this study only access one type of incentive, the monetary. So it's not clear too about how effective for the other type of incentive, such as the rising health insurance premium for the unvaccinated. And the study conducted in Sweden when the vaccine rollout was starting, so it may not really generalize to other countries or in the other stage of the pandemic. And it's also a consideration about the existence of this incentive may potentially decrease the willingness for people to get vaccinated after this if they cannot get any paid anymore. Like they don't want to get vaccinated without paying. And yeah.
I wonder why smaller incentive would be more effective and in intimidation and you first dose.
Maybe not more, but like whether
Because-
paying less can also motivate people to get vaccine.
Okay.
Maybe it can motivate people to get vaccine, but will have less potential of get like vaccine without paying. Like they don't lose much.
You mean the fourth point or?
The first one,
First
the
point.
smaller amount of
Smaller,
money.
yeah. I'm just curious that there is smaller
I
number of
think
incentive.
they consider about this because there is a lot of country that get the monetary incentive and some get a very low amount and some get a very high amount. So they just consider it into their limitation.
I think it just mean it's not clear about the
Oh,
magnitude of
okay.
the incentive.
Money is money.
Yes. But for the governmental budget, so if you can pay less and still can motivate
Oh.
people, then you should pay just like the minimum rate.
And for the thing that they say that the maybe the next booster shot, if they not get paid,
Yes.
they may not, maybe they mean that they can do the like the study.
Yes.
in the future.
Actually, they publish after this group they did for the booster shot. And they can show that it's not, they call it crowd out. That means although people don't get paid for the booster, they still go to get the vaccine. This paper was published in Science and the follow-up one published in Nature.
And the last limitation is that it's made differently if about who provide this money for different government or different companies and the level of trust that people trust that the provider will give their money. So the conclusion is that the study revealed that even in this level of money is also can boost people to get vaccinated. $74. I think it's okay.
That's a lot. Okay, that's a lot.
Maybe it's not much.
Only the meeting.
Because in their baseline is about, in Europe is about 70% for people to get vaccinated without the monetary incentive. So it's get a bit booster, about 4%.
But I mean, at that time, it's like, yeah, people are still very severely sick, so worth it.
Yeah, and by contrast, the behavioral nudges look like it have a very small and not significant effect on the vaccination rate. So that's all for my presentation.
Thank you. That's a nice one. Yeah, so I really like it here because they compare the intervention that people really thought about. Like, should we pay the money for people to get vaccine or this kind of behavioral nudge? So it's very clean experiment. If you have any, should I brag? So two of the co-authors are my friends. So if we have any idea, we can do with them. Yes, good friend of mine. So yes, Eddie. Do you want to have a silent break? Okay. Eddie, are you ready?
Yes, I am.
Okay, we are looking forward to your presentation. Hope you are not that sleepy.
I'll try. Yes.
Okay. will be about monetary incentive again for weight loss.
Yes. Okay, so good morning all. My presentation is on financial incentive-based approaches for weight loss. And this is the paper by Volp, MD et al. And this paper was published in 2021 from German Network. So my research question and objective is can the use of financial incentives reduce the rate of obesity in the United States? Or does economic incentives approach aid in weight loss in the US? So the objectives is to determine whether common decision errors identified by behavioral economics, such as prospect theory, loss aversion, and regrets, could be used to design an effective weight loss intervention. The PICO here, it's adult age 30 to 70 years with a body mass index of 30 to 40 kilograms per meter square. The INC is it's 3 weight loss plans, which is monthly weigh-in, that's supposed to be the control group. And the intervention was a lottery incentive programs or a deposit contract that allowed participants matching for a weight loss goal of 1 pound a week for 16 weeks. So in total, 16 pounds among obese and overweight study participants in Philadelphia Veterans Affairs Medical Center. Outcome here was weight loss after 16 weeks, and the secondary outcome was weight loss after 7 months, which was actually used as the median follow-up. The study design is a randomized control trial study. The recruitment of participants began in May 2007 and ended in August 2007, with follow-up ending in June 2008. So in total, they had 57 participants, which were randomly assigned to participate in either a weight monitoring program involving monthly weigh-ins, or the same program with one of financial incentive plans, which is deposit contract or lottery. So participants were randomized evenly to the 3 groups using a block size of 6 with stratification based on sex and age, 30 to 49 years versus 50 to 70 years. So as I mentioned, there were 3 groups, so which was deposit contract and lottery. Sorry, and then the third one was the monthly weigh-in. So in this process, the procedure was mainly the setting was sealed envelopes generated by statisticians were used within each of the strata, so that the research coordinator who enrolled the participant did not know the randomization assignment of the next participant until it had been assigned. So neither the participant nor the coordinator could be blinded to the randomization assignment given the nature of the intervention. So the inclusion and exclusion criteria, this study included just adults aged between 30 and 70 years with a BMI of 30 to 40 kilograms per meter square. So, and they excluded participants who were unable to give consent, either illiteracy, any participants who had participation in another weight loss program, or unsafe current treatment for drug or alcohol use, consumption of 5 alcoholic drinks per day, myocardial infarction or stroke within the past 6 months, current addiction to prescription medicine or street drugs, serious psychiatric diagnosis. So this is a study flow chart. Initially, they got 958 potentially eligible individuals with mailed participation invitation, and then 165 responded by telephone, and 77 were on wait list. 88 were screened. Out of these 88, 31 were excluded. 18 did not meet inclusion criteria, and 13 did not make appointments. So altogether, 57 were randomized into, and then 19 was randomized to control intervention, 19 was randomized to deposit contract intervention, and then 19 were randomized to lottery intervention. So for the control intervention, 19 completed 16 weeks intervention, but while for the deposit contract intervention, 17 completed 16 weeks intervention and 2 were lost to follow-up. And for the lottery, 16 completed 16 weeks intervention and 3 were lost to follow-up. And then for the control group again, 18 completed 7 months follow-up, 3 participated in exploratory maintenance study, and 1 lost to follow-up. While for the deposit contracts intervention, 15 completed the 7 months follow-up, and then 8 participated in exploratory maintenance study, while 4 were lost to follow-up. And for the lottery group, 14 completed 7 months follow-up, 7 participated in exploratory maintenance study, and 5 were lost to follow-up. So when we look at the control group intervention again, 19 of them participants were included in primary analysis and 19 included in 7 months follow-up, and same with both deposits and deposit contract and lottery intervention. So the methods they also applied here for the deposit contracts financial incentives, participants were given the opportunity to contribute between 0.01 cent dollars and $3 for each day of the month that were refundable at the end of the month if they met or exceeded their weight loss goal. As an incentive for the participants to contribute deposit contracts, they matched their money 1:1 and added a fixed payment of $3 per day. And then they also accumulated rewards each day they called in and reported a weight at or below their weight loss goal, and were provided with daily feedback via text message, advising them of how much money they had earned for that day. So participants in the deposit contract group could earn as little as $0 or as much as $252 per month, depending on what they invested and how much weight they had lost. So, and then participants decided at the beginning of each month how much they wished to deposit for the next month. And then in the lottery incentive groups, they were eligible for a daily lottery prize with an expected value of $3 per day, but only if prior to the lottery being resolved, they had reported a weight at or below their weight loss goal. And the lottery provided infrequent large payoffs like a 1 in 100 chance at $100 reward, and frequent small payoffs, a 1 in 5 chance at a $10 reward. Each lottery incentive participant chose a 2-digit number upon recruitment. For example, 27. So a two-digit number was randomly generated every day. If the first digit generated was number 2, or the last digit was number 7, which was approximately a 1 in 5 chance, and the participant met his or her weight loss goal, he or she would win $10. If the randomly drawn number was 27, which is a 1 in 100 chance, the person would win $100. So both deposit contract and lottery incentive participants were instructed to weigh themselves each morning before eating or drinking and after urinating, record their weights, and call in their weights to the project staff by noon. So every day they were sent a message via text pager indicating whether they were on track towards attaining their monthly weight loss goal and how much they had won that day in incentives. So the results, I'll show you the table below in the next slide. So there was no significant difference in the baseline characteristics of any of the groups. The sample was predominantly male with total household incomes of about $30,000 and a mean enrollment of body mass index of between 33.8 and 35.5 across the 3 groups. Participants in all 3 groups rated importance of controlling their weight to be high on a 10-point scale, which is 9.11 to 9.31, and had high confidence in their ability to lose at least 8.32 to 8.47. So 17 out of the 19 participants in deposit contracts made initial deposit. So 14 of those either held constant or increased their contribution each month. And the average daily deposit contract contribution was $1.56, and the median was $1.49 range, with a IQR of $9.27. So this is the table that I just explained, and these are the characteristics of it. Now, for this weight loss, this is also the 16-week weight loss measure by group. Here, we can see for the control group, the 95% confidence interval is between 0.20 to 13.2, and the deposit contract here is 9.4% to 18.6, and the lottery is 7.4 to 18.8. So at the 16-pound weight loss, we had 95% confidence interval for the control group of 1.3 to 33.1, and deposits contract of 24% to 71%, while in the lottery it's 28.9% to 75.5%. So at 20 pounds weight loss or greater than 20 pounds weight loss, we had about 0.1 95% confidence interval to 26, and then 16.3 to 61 in the deposit group, and 9.2 to 51 in the lottery group. So the odds for achieving this 16 weight loss goal were significantly greater in both the deposit and lottery group, with an odds ratio of 7.7 if we do the calculation. Although they didn't show the table here, they didn't show the result here. And with a 95% confidence interval of 1.4 to 42.7. And the lottery had an odds ratio of 9.4 with a 95% confidence interval of 1.7 to 52.7 groups, compared with the control group here. For the result, again, the percentage of participants losing at least 20 pounds was 36.8%, with a 95% confidence interval of 16.3 to 61.6 in the deposit contract group, and 26.3% with a 95% confidence interval of 9.2 to 51.2, which I just mentioned, in the lottery group. So these participants each received a $50 bonus, and deposit contract participants who lost at least 20 pounds each received an additional $46. So their share of the total amount fortified by the participants in their group who did not lose weight. All but one of the participants in the two incentive groups completed the study, with 33 of 38 having lost weight over 16 weeks. So over the course of the 16-week study, the average amount of money earned in weight loss incentive was about $378.59 in the deposit contract condition, and $272.80 in the lottery condition. And here, this is a weight loss from the enrollment through intervention and 7 months follow-up. So if we can see here, this is the mean. On the left-hand side is the mean cumulative change in weight pounds. This is given in pounds, and the one above the zero is a balance, and the one above the zero is when you gain the weight, and minus is when you lose the weight. So for the 4 months, if we look at it, participants in each group. Okay, sorry, let me tell you what each sign stands for. The triangle here, it's for the control. The block is for the deposits contract, and then the dots here is for the lottery. So if we look at the 4 months, in each group, participants regain weight following.
You can actually here show
Sorry?
the whole distribution, because you only have 19 participants in each group. That's why I think they show the whole, like the whole points here.
Yes.
For each participant.
Yes.
Yes.
Yes, you're correct. So participants in each group regain weight following the conclusion of the intervention. At 4 months, those in the incentive groups lost significantly more weight. Yes, if you can see, they lost significantly more weight than those in the control group, with a p-value of 0.02 in the lottery group, and 0.006 in the deposit contracts group. But at 7 months follow-up after enrollment, the weight difference between groups was no longer statistically significant, with a p-value of 0.23 for the lottery group, and 0.61 in the deposit contracts group. So Well, those in the incentive groups experience a net loss between enrollment and at 7 months interval, whereas those in the control group did not experience this. So for the strengths and limitations of the study, for the strength, this study demonstrates the effectiveness of incentive system based on behavioral economics in promoting weight loss. Loss to follow-up rates were much lower than its typical in weight loss studies, suggesting that this approach was successful in keeping participants engaged and significant weight loss was achieved without coupling the incentive programs with an intensive or expensive weight loss program. But the limitation here, the study was limited to just veterans at a single facility and had a low percentage of women. And also it's unknown how the effectiveness of this type of program might differ in men and women. So we can't really use this. And because the study population consisted of patients who volunteered to participate, study participants were likely more motivated than the average obese patient. They also have only limited data on the sustainability of the intervention, and longer term follow-up would be useful. So in conclusion, they concluded that the incentive approaches based on behavioral economic concepts appear to be highly effective in inducing initial weight loss. However, effectiveness and cost effectiveness of these approaches needs to be tested in achieving sustained weight loss. Thank you.
Thank you. It's the issue of financial incentive that better is crowd. We call it crowd or the motivation. That means once you get the incentive, then you are motivated. And what happens if we don't pay the incentive anymore? Better people like maybe they don't care about that behavior anymore. So maybe it's backfire even backfire. So that's the topic that quite hot as well to study. Okay, Eddie, so are you awake?
I'm trying to stay awake. But just in case I'm sleeping, well, you need to pardon me, please.
I see. Thank you so much. So
Yeah.
I think we are taking 5 minutes break, and after that we try to do the workshop. So Eddie, maybe you can like listen to, I will go through the worksheet a little bit so that you can listen to the explanation, and then maybe you can try to do by your own. And then if you have any question, you can email me later too. Okay.
Okay, thank you. Yeah.
5 minutes break, and we will come back at 11. Would be so you will design your own intervention. Please first just come like you can imagine anything. So you don't have to think about whether it's possible in your context or not. But of course, I think you will think about it. But don't focus on that. Please focus on the intervention first. I have to share for Eddie and the Ajahn on. Okay, so I think because you are only 4 people, maybe you form a group, like all of you together. Yes, a group. And then yes, the objective is to decide the intervention. So first you should think about the desired outcome that you want to achieve. For example, like it should be outcome, not behavior first, just outcome first, like less CKD, for example, or weight loss reduce something, yeah. And then to get that outcome, next step, you should list the behavior that you think will lead to that outcome. For my example, desirable outcome, late CKD patient. So here, behavior, or if it's individual, you can think about individual as well. Like the outcome should be less probability of getting CKD, for example. Then behavior can be, okay, I will consume less salt, then less frozen food, less fish sauce, things like that. So you just try to list whatever you can think of, okay, as behavior here. And then maybe you list, or you don't have to fill out all this block. just in case you have a lot of ideas. Then you choose from here, like only 3 or even 1 behavior that you want to target. Okay. In my case, I would say, okay, I will choose late fish sauce. And then next one, you think about, okay, I would like to reduce my fish sauce consumption. Do I think about that as individual behavior? So do I do it on my own, or maybe it's easier if I ask my lunch friend to do it with me, for example. So who will perform this behavior? So only me, or if you think of your intervention as a group intervention, then you say, oh, no, sorry. So that's the easy thing that I think only about me, so it's me. But if you think of your intervention, if you are like occupational, what is your title actually? Occupational medicine. Okay, so maybe you think about intervention for workers in a factory, for example. So you can say factory workers. Or for you, it may be, I don't know. So, and what should they do? So what will they do? Like you try to specify where and when, and should it be a group intervention or individual? You can, so everything you can design, okay? How often? And then next one is about outcome measurement. So the description of the outcome of that behavior. It can be many things, right? So for one behavior, you might have different method or different measurement. Like fish sauce that they consume each day, or the goal. It can be the goal, whether they achieve the goal, and then you have different units and procedure to measure. Okay, the next one is like actually the biggest one. So you need to think about the intervention now. So here is, so first capacity, opportunity, and then this motivation. And so I list out everything that we talked about last time. So psychological, so this is the description, and then you might think about intervention that can address psychological capacity domain. Okay, and this physical. So, but again, you don't have to fill out for everything. So just the domain that you think you can think of the intervention. For example, here, psychological capacity, I could say to say you should consume only 15. I just come up with any number, 15 milliliters milligram of fish salt a day, for example. That's very hard to remember and to know how much it is. But my intervention could be, for this domain could be that I will inform my participant that they can only take 2 teaspoons of fish salt, for example. So it helps with psychological capacity because you can digest the information easier, right? So inform that maximum consumption of fish salt daily is 2 spoons a day. Or if it's about diet, you can use, for example, so label, traffic label or something like this. That, yeah, opportunity you can think of. But physical opportunity would be very, mostly community level intervention. So you can suggest that it's okay. No? You can suggest that here as well. So first, don't think about whether it's feasible or not, or on your own now. And motivation, it would be reflective. It's about yes, evaluation, goal setting. You can add about goal setting or plan, help them plan or something like this. And then for automatic motivation, it would be this MySpace. So you can try to use MySpace to tackle this. But again, of course, if you think a reminder would help here, social psychological capacity, you can add here as well. It's okay. Like you, if you think about, you inform your participant per SMS, for example, you can use reminder here. So it's like not that you can only use reminder here in this domain. Okay. And then how you will deliver your intervention, so you can choose by circling the channel. This I don't think you will have time, but it will be your assignment. I give you 1 month assignment. Okay, but at the end, if you don't have time today, it's okay. But it's just that after you have your draft intervention, then you try to evaluate it here. Try to evaluate it with this criteria, whether it's affordable, practicable, and these are the description. Affordable means, yeah, of course, it's cost effective. No? And practicable, whether it can be really conducted. Yes, and then whether people will accept it. Like you can see from this deposit contract for smoking cessation program. Maybe people don't accept it because they don't want to pay first. But you can have, you can adjust how you deliver the message, and also even for deposit contract, you can like let people choose their own deposit. Maybe if it's not too high, they can accept the deposit as well. And then you talk about side effect of safety. Maybe there are no, then you say no. And whether it's, yeah, equity, whether equity is there for your intervention. But that you can do it later. So let's try to, yes. Yes. Good question. So, so you can list down, like you can brainstorm, and you might have many ideas, and that's why we have here. Here I don't have it, but I think in assignment, here I have it. I see. So I use like the intervention that you showed. You should like put a star after that. But I will revise the assignment. Maybe I will add one page more that at the end you choose. I think I have it, but let's see. In the assignment. So in the assignment, actually, so after you put some ideas that I think it helps you think through, and also it helps me see that you thought about all the domains, and then at the end you describe which element that you choose to like try to conduct here. Yes. That's it. Answer your question. But for today, I don't think we have much time. So just try to think about all the domains and yes. And just indicate for me like, I think I will be with you. So you are only 4 people here. Yes, which one you still think, yeah, you would like to try in your imagination. Okay, so actually I try to put how long you should spend in the step, but yeah, I don't think we have much time. So let's start. And Eddie, you can try by yourself. That's why I gave you the word file as well so that you can type. But I also give you PDF. So if you wanna write on iPad or anything, so you can do with whatever media you want. And so yes, but for today, I think you all do it together. So do you have? Okay, you should somehow discuss and come and agree on the desired outcome. You wanna do four of you together or 2 pairs? Maybe it's easier to agree on the topic. I don't know. 4 together. Four together, yes. It should be healthy. Yes, that's very specific.
Good. Lower than, if you have no risk, it's gonna be lower than 130. Better, the lower the better. So lower than 100 is not helpful. Yeah. So everything already.
I do like for. The individual level of I don't think yes, this will be big.
Oh, yeah.
But she's still there.
Maybe you can attend that class.
And under which web that you been given.
When someone plays.
Inside our house, we just stay only the outcome. Yes, first only the outcome, and then after that you literally the year. You can think of any. So, so police for me.
Yeah.
But if she said okay, if you can share. Vegetable consumption. I also want to.
Implementation.
About normal population.
Some of you may. Some.
The more detailed word
So,
whatever
reduce.
but it's hard to calculate for right now in our hospital, this is the season for our staff health examination and most of our people have very high level of LDL, like 180 and this is about told me like, oh yeah, I have the top weekly, like some of them have 2 or 3 times per week. You can say skin barbecue
Smoking cessation. Also alcohol. The use of alcohol making.
Okay, so choose one. So you talk about these 5 of these individuals. So please choose only the one that you are working on.
So it can be, I mean, it can be anything, right? That doesn't mean that it doesn't have to be like both effective, but right?
It can be, or if you have research, and justify what is said. But the effective.
So all these, if you're talking about the effectiveness first, effectiveness is take medication, but as we can say that. So you cut the medication out, and then the second one is the exercise.
But if your population is 45 or medication can be a very expensive. Here and
So
right now you talk about it more, but so.
the exercise. So if we do it myself, maybe my desire of something like maybe hospitalization in
That's all. Okay, so right now we use it.
Yeah.
Or to like control every in the room that have every attribute one that and the one that is the one that Okay, so this you choose exercise and regular multiple and 5 parts of the exercise and you know you have to go by one. First, for your exercise. But of course, you have like a big project. If you have a big project, you have to tackle maybe bigger but not to do because you are alone, so the funny okay, so let's go to what exercise for that. What really for actually whatever.
Mostly. Not pretty sure. Medication. So they low use of
exercise more than one
Oh, so
general population. Five minutes.
so it's okay.
But you cannot say general, you should say more specific.
So based on what I can say, so it can be like the healthcare worker who have LDL. It's higher than the normal. So the group you perform is very good.
So here you have to think about the institution who like to target. Like that, it can be very specific, like you can work yeah, in one hospital or so it depends on your student. Yes, who's your family? Or if you say self-care workers mean across Thailand or what? No level or
Officer in CED.
There. Next day, keep saying. Or do you know
What
like you know, it's hard to say 150 minutes. To break down.
So what will they do? Meaning that maybe they can do the cardio exercise for like 30 minutes for 5 days a week, like that. About
Can be like we can be have options like there or at this down here. Or
That's why here you actually input because
so I think we meaning that we can like or whatever.
and the more specific, the more precise can be.
So cardio is
broad or specific.
cardio training cardio is one kind of exercise that takes a lot of going up. And in cardio you also have like the heart rate of it. You can have like visualization for the
Specify.
so
What?
okay. Oh, but for I mean for this will come to more individual, like because everybody will respond to the same thing. Like if you say that you're running on the treadmill for like inhibition of one at the rate or maybe 6, maybe like that, and someone will get vigorous training and someone will get something like 100
But it's okay for us not. Like we got me focus on it.
it is not the vigorous will have some role, yes. So if you do vigorous training will take you only half of it. Like if you need 150 minutes per week for normal cardio training, but if you do vigorous training, it's only need 75 per week.
I don't care so that the detail, but you can like give example.
But in all,
Yeah. For example, they run there. Oh, we can store แบบตั้งต่อที่เชลล์เป็น store เลยแล้วก็พวกจริงน่าจะมีที่เป็นแบบเป็นผู้แบบแล้วก็เป็นห้องแบบให้เงินแล้วก็โอนแต่ไม่เปิดพื้นที่ที่เป็นร้านเนี่ยจะทำเลยน้อยไม่มีแล้วก็เป็นสบายเลยจะมีห้องแมชชีนWalking home.
Walk to Rama.
Walking is how everybody will go.
You have walking, you have walk. But if you just walk like you walk sometimes.
How you can reduce the what do you want? I don't know. There we go.
So, it depends on your background. It depends on your background.
How many percent that would you count as fast? I mean, how is it higher than 120?
But normally, that is like it's but mostly you have to take out it from a check with that happening.
I mean, normal walking is still count as
We can count it, but the ideal training, it can improve your muscle strength. It improves the muscle strength, it improves the posture, but it doesn't improve your like if you want to lower the
exercise is okay, anytime.
Yeah.
Anyway, you are like work and then all
Being cool.
hard for people to follow, to be to accept, to let they walk in. Would be
So, like we have teaching both.
yeah.
But if they want to walk around, like go there, or if they want to like play, because it is there.
If you like, you still have more motivation. Around. So you have like idea already. So we can go to the. So the next one we could think about how to get the behavior. That means how you should have like sometimes you have surrogate on 1 year. It will have some about the behavior itself. And then you have that desirable outcome is to be of study element. But also how it is. And you know how it is, but it can be different outcomes as well. Like the minute or the day in the week. Yeah, and then how you measure each of them. Okay, so that's calculate, but I think so. So we like exercise what like we know is the outcome. Yeah.
Gonna be especially the midday. So this is like that it can be also
Okay, like if you think about it, how they use the data. Actually, we go in that. If you can have this, I think the class is but it can be self-report. So it's not optimal, but it's better than. But of course, you can, you know, and just think of the place scenario. Just say, that in the but of course, if they walk in there, if you do the step, walking step, you can say, for example, the step from the device. Or 100 one. And then how we help for this will be used for the you know, one I to do in the rules. What they will I do. And also if that one outcome is equal. If the goal is exercise 5 days a week, then one outcome will be that whether they will be only 4 days fail on that. It can be number of weeks that we achieve the goal first. And then we can look in starting from so for now when you I would say nothing else. So explain your support. But currently I'm not that important for that individual. So it's flexible with the can be like the physical capacity or so my people will be some people that people like you will have 5,000 or you can buy like you can buy like or if you want some economic or the best support. So preventive right. I think it's like when you try to deliver the information in the easier way, right? No exercise to reduce cardio. But then when try to break down, like if you say cardio 100 minutes, so it is like people what they do know how they should do it. So if you say, so that you kind of short of breath in that level, 5 days for half an hour. So kind of easy to imagine what they want to do. Can I do it? Yeah. Really? So it's the same. I do 5 days.
Yeah. And then you can do it in 1 day. You can do it 10 to 15 or 20.
For 1 year. I guess it can be enough.
Yes. So if the outcome is how to say prevent the overspending, how to say that the only give number of others.
Or you can do infographic. Okay, then we will do also a passport. And then you go to buffet. Okay, yeah. and orange.
So we need to do it.
Okay. Okay, you are right. What is it? But then you can combine, I told you, information but in detail. But it is that's okay. Then I will. What we talk about that okay breakdown that's the breakdown like so can ask them to choose first. Some people like to do like 30 minutes. But some people like to have the small pieces 2 hours a week. You can inform them that it can, hey, that's my extra knowledge. And you know, that is the thing. I thought that we need to contribute.
But the
Can maybe you're not.
so maybe you have like we training or like 10 minutes and then we protect it and then because the time that is now is just that it is like already.
I can like think about presentation, then my father would about right meeting with a then my is that okay and then you have to go. Yes, very, very different. So you have to like this more of studying and some want to run, some want to swim. Does you say that
So if I say that in every month there will be like competition of new competition like that.
yes.
Can you see? Okay.
Actually, now you know this, like I said, this aspect, but this framework they try to give you the framework to think about the things that are in aspect. That's why something might fit into both things or things there. It's not a clear cut. Something for the for the business and leaders. Yeah, for the yes. It's more than 130. We one more example of this mindset. Like you can also use commitment. Or when we talk about like we saw the deficit to motivate people, right? You can put it in because that deficit context actually they kind of they design the incentive using not of which for
the center that we give to get the make them take a lot of time. Yeah, very hard. Things like that, and then you can try to think about interview, but it's okay if it cannot take long. It's okay. And then at the end, like I told you before in the essence, if you want to do this, please take the one that's fine. So like condition or modification. No, I just give you a thing. You might want to tackle before, tackle the and yeah, so we say that you want to reach your that's the that you want to do is that population is all population and only your family. Okay. And then you have to get it. Follow now. Always I can't find you for and then one of the house.